So our goal was to look at how the disease burden, the cost of burden would change, especially the cost of treatment. We know that there have been several issues with the cost. Payers are not able to provide timely treatment to patients because of the rising cost of the drugs. So we wanted to know how much would it cost to the society in general to treat everybody who has been diagnosed with hepatitis C, and how much would it cost to make hepatitis C a rare disease in the country. We published a study last year showing that Hep C can become a rare disease by 2040, around 2040, and then in this study we looked at the cost of reaching that projection. So we started projecting the disease burden year by year. In 2010, before the launch of DAAs, the cost of hepatitis C care was around $7 billion per year. With the launch of DAAs, in addition to the expansion in insurance coverage because of Affordable Care Act, plus because of the impact of screening updates, the cost of hepatitis C care jumped to $22 billion this year in 2015, from $7 billion in 2010 to $22 billion this year, and $17 billion we are spending on treatment this year. Number of factors. Medications are more expensive. Number of people we are treating is very large. Number of people who are aware of the disease is large. People who have insurance now is increased. So multiple factors. For patient care, I think if they're getting care, it doesn't mean much. It's a good thing for them. It's all wonderful because they can get care of the disease. To the healthcare system, it means a lot. Because we still are not able to treat everybody who has been diagnosed with hepatitis C. So we have to further increase our treatment capacity. How do we do that? By removing restrictions. For example, Medicaid has restrictions on who can get treatment. If patients they have history of active injection drug users, they are not reimbursing for drugs. So removing these restrictions will definitely help. Earlier in the year, we saw that several other payers were also restricting treatment based upon the fibrosis, a degree of the disease severity. People who are more advanced should get treatment, whereas less severe should not. Right now, they should wait. So we have to remove those restrictions. There are a lot of issues with that because we think our system was not prepared for this. So Medicaid, for example, did not have budget. They did not have allocated budget to treat everybody. They would anticipate getting drugs next year. So they decide the budget 1 year in advance. Similarly, VAs, where the prevalence is also very high, Veteran Affairs, they did not plan for this very well. So because of these factors, there is a restriction on the budget, how much they can allocate to hepatitis C. That means they have to remove budget from some other areas and put them on hepatitis C. So that's probably one of the limitations of the system. What would be the reason? If the reason is that they don't have insurance, then what I've heard is several pharmaceutical companies are providing assistance programs. They can approach them to get treatment. If the patient is on Medicaid and Medicaid is not reimbursing, so that's a very unfortunate situation. I don't know what to say to the patient, but it seems like the patient would have to wait maybe a year or so at least. When the more budgets available, these patients will get treated. Costs may not go down. We have seen some discount. Payers are getting discounts because of the competition now. So practically there has been some impact, though the listing price remains the same in that $80,000 to $90,000. But practically what we are paying is much lower than what we saw last year when the drugs were approved. But what's interesting finding of our analysis is that the burden is declining very sharply in the next few years. For example, by 2020, the total spending on hepatitis C would be below $5 billion because we would have treated most of the patients, a big number of patients who need these therapies. And by 2030, that's when we anticipate generics would become available in the US. We would have treated most of the patients and they would not have any impact on the cost of care. Another objective of our study was to look at how much would it cost to make this disease rare and we found that its total it would cost $106 billion, which is a substantial amount of money. But if you compare that with HIV spending, in the last 5 years only, we spent $144 billion on HIV/AIDS. So, and we have several studies have been published that show that number of people dying from hepatitis C in the last few years is more than that from HIV. So one of the limitations of this work was we did not include the institutionalized population, like people who are in prisons, homeless population. The disease burden is very high in these two populations. So how do we bring these people into the system, and then who pays for their treatment? So that's a big question. So before the launch of DAAs, we found that number of viremic people who are HCV positive and still need treatment was around $2.4 million. And then in this year, 2015, we projected that around 2 million people need treatment. And moving forward, by 2020, less than 1 million people would need treatment. And then we also looked at how many people are aware of the disease in this year, and then how that would change in the near future. We found that around 900,000 people in this year still don't know they have hepatitis C. And even in the next 5 years, in spite of the screening updates, screening policies for hepatitis C, by 2020, we still anticipate 500,000 people would remain unaware of the disease. The message here we project is that there's no doubt DAs would do very good in reducing the disease burden, but the burden still remains very high even in the era of DAAs, because we now essentially have a cure of a disease, and still we see that many people would advance to these adverse outcomes like liver cancer. They could die from the hepatitis C. So we definitely need better screening, and then how do we provide treatment to those people who would be diagnosed with hepatitis C. Then another population that's growing is number of people who achieve sustained virologic response, which is the surrogate of cure for hepatitis C. However, many of these patients would still be at high risk of developing hepatocellular carcinoma. So we need active surveillance in these people, otherwise many of them could advance to HCC or die from liver disease. I think it's for everybody, because they are, if now we're calling them patients are cured, we're not calling them patients anymore. So they may not be going to hepatologists regularly, so they may be going to general practitioners. So they need to be aware of this population because they still have high risk. Well, we hope that we would have treated majority of patients who were aware of the disease. Even like we would have diagnosed more and more patients in the near future, and we hope that it will not be a serious disease anymore.